We're just starting right now. Okay, welcome everyone to today's webinar. It's a capacity strengthening webinar series with program spotlights of multi-sectoral integration with IYCFE. Today's webinar is on integrated family planning services with mother and baby nutrition areas in the Rohingya camps in Cox's Bazar, Bangladesh. I appreciate everybody's prompt attendance. It's wonderful to see the good turnout. It shows that there's an appetite for trying to learn how to do more integrated programming. Okay, so first I'm just going to go into a little bit of background on what we're going to go through on today's webinar. First, we'll have an introduction of the webinar. I'll have a very short, brief TechRRT overview so that you know who we are and why we're interested in doing these webinars. Then we'll have the actual main part of our webinar today. It's the program spotlight, where we'll have Noem Udin. He's the HMIS manager with Save the Children Bangladesh, and he's going to be doing main presentation, and I'm sure he and Katie will be the main people to answer questions about the program that they have. At the end, we will do lots of questions and discussion. So we aim for this webinar to be maximum an hour and a half. It might be an hour. This depends on how active our discussion is. But with such a important topic that we've been trying to tackle for a long time, I'm hoping that we'll have very active discussion. So please don't be shy. Okay, the aim and the objectives of today's webinar. The aim is to increase integrated programming for IYCFE, and it's taking advantage of all opportunities to put mothers and babies at the center of the response. With that, I will, I should have put the link here. I will give a small plug for one of my favorite initiatives. It's the IYCF Friendly Framework that Save the Children has out. There's a wonderful video where you can learn about Sarah and her baby, and a fantastic demonstration of how integrated programming and mother and baby centered programming can have a great impact on children. Okay, so the objectives of the webinar are to present practical examples of how nutrition, and specifically IYCFE, is being integrated within other sectors' programs. This is the objective of the whole webinar series. Right now, you guys will have seen that we have 4 coming up. Today's the first one of 4. I expect that we will continue in the fall. This was our initial, the initial ones that we were able to put together, and we wanted to start it off, and we know that there's lots of other programs out there. I expect the fall will continue some in WASH and other sectors. Okay, so another objective is really to discuss the opportunities and challenges of integrating and how we can really do more of it, how to practically do more of it. So right now we see lots of people talking about integration, but not a lot actually happening. But obviously this webinar series is going to demonstrate some of the things that are going on. But for us to actually start talking about what are the obstacles to these to this happening. Okay, so this webinar series, it's brought to you by Save the Children and the TechRRT, the Technical Rapid Response Team. It's an initiative within the new Global Technical Assistance Mechanism for Nutrition, which we'll be launching in the coming couple of months. It's in close collaboration with the Global Nutrition Cluster and UNICEF. And I wanted to give special thanks to Save the Children and the IFE core group for the help to make this series a reality. And I am confident that it will also be a success, so to make this series a reality and a success. Okay, just briefly, what's the TechRRT? The TechRRT is a technical rapid response mechanism that deploys advisors to support improved nutrition programming. The aim is to improve the technical quality and scale and reach of the response. It's accessible by any organization, can be for groups of organizations together, can be a cluster or a sector. It can be for individual organizations, local, national, international. There are no boundaries in that regard. It's a consortium that started in August of 2015. International Medical Corps is in the lead with our very close partners, Action Against Hunger and Save the Children. We have funding right now from USAID and Irish Aid, as well as Swedish SIDA. We work in close collaboration, as I said in the webinar, with the Global Nutrition Cluster and UNICEF, and we're within the Global Technical Assistance Mechanism for Nutrition. Okay, today's presenter is going to be Noem Uddin, who currently works as the HMIS manager in Save the Children Bangladesh. And today we're here to share his experiences with the program that they've initiated. Before I hand over to Noem, I just wanted to say out loud, if you have any questions, either about what I've already said or about during the presentation, please feel free to write them in the chat box. And then we'll collate those questions to make sure that we raise them at the end, to start with those and then be able to go into more discussion. So feel free to be active. Okay. I'm going to hand over to Noem now. And just give me 1 second to see about sharing my other. Okay, just a second, Noem. Oops. Can you guys see my Save the Children first slide?
Yes, we can.
Great, okay, fantastic. Here we go. Over to you, Noem.
Hi, Andy, thank you so much. Hello, everybody. Greetings from Bangladesh. So happy to be here. I think it's a great privilege to share our experiences from the ground. And so I want to start with our recent experience with the Rohingya Response Program, that we integrated our family planning services with our nutrition IYCF mother-baby areas. And let's go to talk about some background of this integrated program. So many of you know that in last year, 2017 September, we have more than 100,000 Rohingya refugees in Cox's Bazar who crossed the border from Rakhine State and Myanmar. They're seeking safety and essential services while they're fleeing. And this massive Rohingya influx has created a huge burden, not only in Cox's Bazar health system, but also the countries. So the women seeking their reproductive health services are among the most vulnerable. And Rohingya Response Nutrition Team. So the response so despite a large public health response from the government of Bangladesh and international actors, including service targeted our women reproductive age group, the needs of this population are massive and low. So the UN agencies, they showed that 22% of pregnant women deliver in facilities only, and women reproductive age group face immense physical and social cultural barriers to accessing reproductive health care they deserve. Many of we know that the cultural and social stigmas across the camps are really plays a vital role here. Like when they birth their babies in the at home instead of the facility, it's because of their misconception, their social stigmas, many of their misbeliefs. Like during their ANC and PNC, mothers, they don't actually want to come from the tent. And these mothers, they also do not have that much decision-making capacity within the family. So the husband, like gatekeepers, like their mazis, religious leader, then their mother-in-law, they also plays a key role. So all of this, due to all of these reasons, so the pregnant women, and then after that, the reproductive health age group mothers during their PNC, they actually do not want to come out from their home easily. So that's what the reason that we started this integration. Can you go next slide? Yeah. So in January 27, our Rohingya response, our nutrition team opened mother baby area at each health post for infant and young child feeding support, targeting that our pregnant women and women with children due to 23 months to protect, promote, and support our recommended IOICF practices. Breastfeeding included our breastfeeding counseling and other things. So the reproductive health and IOICF teams realized that we are targeting the same population of postpartum women.
Sorry to interrupt you, Noam. Can I ask everyone, please, to mute yourself, particularly if you're talking in the background, okay? Because it makes it very difficult for everyone to hear Noam.
هو عامل هو ريكورد انسان لانه بحاول السكريبت الحين افتحها اخليه بس اشوف عمر لها عايش يصلحها لي بس ما اعتقدش ان الاجهزه الكبيره فيها
Sorry, maybe Andy, you just need to.
Okay, everyone, I've muted everyone and I've just unmuted you, Noam, so I think you can continue.
Okay, thanks. So that when we started the program and we are struggling with getting our target people, actually the pregnant women, and then our reproductive age group women, and then we realized actually we are targeting the same population of postpartum women, and we were just brainstorming with our colleagues, our Saviors colleague Katie, that how we could do actually the integrated program so that both targeted group from RH and IOICF teams, they could benefit from an integrated counseling and referral system. Next, Andy, can we do next slide? So the integration of MNCH services, or maternal and child health services, to promote uptake of family planning services has a strong evidence. So the both nutrition and RH team missed out beneficiaries. Some going to reproductive health, but not the mother-baby areas, and vice versa. So due to unawareness, our weak referral system and poor integration system. So while both teams, we started integrating awareness sessions into by some trainings for midwives and our lactation counselor, IOICF counselor, and community health workers. It actually more could be done. So it started with these training programs. Both of our teams and build up their capacity in ground. Okay, can we be next slide? So although the integration of maternal and child health services to promote uptake of family planning services has a strong evidence we have, but we don't know details about opportunities for integration of family planning and nutrition programs like IOICF in emergencies. So in order to evaluate the potential benefits of integrating breastfeeding services with family planning, we established a robust monitoring system that actually was put in place to track our referrals of clients between the mother-baby areas and the family planning counseling room. And the process actually started with one of our colleagues, external consultant. She undertook a desk review and the semi-structured interviews and a group discussion to identify many barriers and facilitating factors for the integration of IOICF and reproductive health services. So So she went down to the field level and discussed with our field-based staff, our frontline warrior, our IOICF council, or our midwife. So how can we actually increase the number of beneficiaries, especially these postpartum women, so that both both teams, RH and nutrition team, we can benefit. So the analysis surfaced that integration of IOICF and health programming, especially for the emergency response, came out as one of the important recommendations. Because both teams actually targeted the same group of beneficiaries, postpartum partum women. Maybe a mother brought a baby in IOCF corner, but they missed the family planning services due to unawareness. And then in the same hand, maybe a reproductive health corner, a mother came for family planning services, but they missed the IOICF counselor rooms, so they missed the breastfeeding counseling. So that's why we targeted that we should actually start with the integration of programming. So the in this emergency response, Rohingya response, it actually, we hoped that it will definitely work by this recommendation. So that our integration process actually started with our some background work. We added a extra column, both IOICF and family planning register, so that we can cross-check with the beneficiary number, and then we do monitor in the field level. So we asked our provider, midwife, and our IOICF counselor if the client was counseled on family planning or breastfeeding. So they will do count the number in every day regularly, and then it will then reflect in our daily output tracker, and then we do the health impact monitoring system, so that at the end of the day we can cross-check with both nutrition output tracker and health impact DHIS2 system, so that we both team in a same place. And after a monthly meeting, both team can present how actually we do successfully integration program. And then we also introduced the referral slips that actually were given to women interested in family planning methods, and clients were escorted to the family planning corner at the same site. Referral slips were collected from the family planning corners and cross-checked with nutrition output tracker that I mentioned earlier, and it actually worked as our main source of data verification at the end of the month. So we actually try to do a strong monitoring system, so that the health team, like the midwife in the field level, and in the nutrition team, the IOICF counselor, both teams, they are in same page. So whenever like a nutrition corner, I mean the IOICF counselor maybe referred 5 mothers in a day. At the same time, we try to ensure that our midwife also received the same number of mothers from nutrition, and it's actually vice versa. If a midwife also refer 2, 3, 4 mothers to our nutrition counselor, we actually, by using this referral slip, we actually try to ensure that our nutrition counselor, that she also received the same number, because in the camp level and the health post level, in every day there are more than 100 of patients, they are coming, even only in the health post. The nutrition, the number would be high if you count nutrition, MHPSS. So we actually try to using this several tools, like referral slip, then the register, so that we can ensure that our integration program should be, do it best way. Like if you refer a patient from one corner to another corner of a health facility, it doesn't mean that the patient actually will reach in the right place. So we actually ensure by using these tools in every way that we actually ensure the right number. If we miss some number, then the same day or the next week we actually talk with our nutrition managers or nutrition supervisors in the health facility or the medical doctors, so that they can aware our colleagues that we actually miss some beneficiaries, so that the next week they will be more aware to get to ensure our strong internal referral system and integration process. Can we go next year? So when the integration process started, the both teams actually we providing awareness session during some trainings for midwives and IOICF counselor, including our family planning assistant. So we actually discussed family planning issues, our breastfeeding and integration protocols. And in second layer, we actually aware all of our field level colleagues like nutrition supervisors, the health medical officer, clinical supervisors. They were informed about the integration process, and we asked to support their support, so that we not only build awareness only our field staff, I mean the frontline staff like IOICF council and midwife, but you also, at the same time, you also ensure awareness program to their line manager, like the nutrition supervisors and the health medical officer, and then in the upper layer, the clinical supervisors, all informed about this integration process. We are doing a great work, and then whenever the field level staff they need any support, that they can do accordingly. And at the same time, colleague who based in Cox's Bazar, like the senior colleagues, the reproductive health manager, our nutrition senior manager, health advisor, nutrition advisor, they were updated during monthly meeting on how the integration successfully benefited both teams, and if there are any gaps, they even some cases they do suddenly they start discussion in the meeting, and then they kept very aware and that these things to be done in field level, and they acknowledged our initiatives, and then they encourage field level colleagues from their both team side. So the initial result found in that our MBA and family planning integration was implemented from April 2018 to June 2019, and we found that there are more than 20% increases new family planning contraception acceptors. So that is very encouraging that we received our initial results. And IOICF is indeed being delivered through our reproductive health services, and midwives had a very good working relationship with the IOICF team, because many of we know that I think we all agree on that point, that when our reproductive health services, the midwife provides services during antenatal and postnatal care, definitely there should be discussion for family planning and both breastfeeding counseling. So both teams, they actually work very closely in the ground level. So the group discussion with the midwives, we revealed that they can provide basic breastfeeding messages. So focusing on recommending early initiation of exclusive breastfeeding even it started during ANC, then even after the delivery as well. So carry out a breast examination as part of our ANC and PNC, and observe a breastfeed when relevant. And our IOICF counselor, they also simultaneously started discussion family planning options with women who seeking IOICF services, something that was maybe never done before, because there are some true story I saw in the Rohingya response. We found one of our midwives found that a mother she never experienced with a family planning method like a condom or a oral contraceptive pill, anything. So whenever the first time our midwife showed her a condoms packet, then she asked how many times she need to take it. So she maybe thought it's a oral things. So across the Rohingya response, all the camps, people, our mothers, they really don't have that much family planning knowledge, and the knowledge, huge knowledge gap, even because their husband, they also sometimes made a barrier for them. So the training of midwives and IOICF counselor actually enhanced the quality of both of these counseling session, because when the training came out, the midwives and IOICF counselor, they even understand they actually targeting the same beneficiary. Now they even both team, the midwives and IOICF counselor, they actually opened their eyes. They asked both of them like on each other that, okay, there are some problem, maybe one of our beneficiaries shared with me. So then the other teams, other colleagues, or maybe IOICF counselor replied, okay, so I handled this problem this way. So maybe then a midwives and IOICF counselor, they both discussed in the training, they had some demos, they have had some discussion problems normally the beneficiary talking about. So all of this training and between the midwives and IOICF counselor actually enhance our quality of both counseling sessions. And IOICF staff, they felt very confident when they're discussing the family planning messages and encouraged referrals to the midwives for contraceptive services. Because even in if we think about the technical things, even in the breastfeeding, if we do normal breastfeeding to our children, sometimes it also works for our family planning. So both family planning and IOICF, these things are very well connected in between. So the colleagues, they feel very confident when they're discussing family planning messages, and they showed the beneficiary the real changes on her body and the family, that if they do use family planning and IOICF together, it really worked, and it really will come at the end of the day, come with a very good outcome, not only her body, also for the family and for the baby. So the beneficiary mothers found them to be very friendly services, they helping to avoid loss to follow up. So sometime even during when we started, we thought that we have to ensure that family planning and the IOICF both facility at the same point. I mean, like at one stop point. But sometimes we're missing our family planning and beneficiary. So normally maybe the IOICF counselor, maybe they referred to the midwife in her reproductive health room, but on the way to the midwife room or the reproductive health room, sometimes beneficiary missed. And when we found it, both difference between both nutrition output tracker and then our reproductive health, our own register, the difference of number we are referring, the number is different. Then we started discussion with how we ensured that, so that we engaged a volunteer, or one of our volunteer in the health facility, so that they brought our mother to show the midwife room. Sometimes they felt very shy to go to the family planning counselor room, I mean our midwife's room, because most of the mothers, they are adolescent. So these mothers, they are they felt very shy. Sometimes they didn't talk about the family planning issues. So then we started with bringing our mother from my family, IOICF room to the family planning counselor room. So it shows a very good result. And then when it was started, we got a very good result. So if you see the graph here from okay, so if you see that the graph from June 2018 to September, you see that mother baby areas staff refer almost 350 new family planning etc. each month, and that is over 20% of our new family planning etc. at those health posts. So Save the Children has our 9 health posts, and every health post we have a nutrition IOICF corner and a reproductive health corner as well. So MBA and family planning integration referral system, it actually benefited in both cases. So 20% of new family planning accesses we found during this time. And if you see that the next phase in November 2018 to February 2019, our mother baby areas, that is staff, they refer to 350 new family planning acceptors in each month, and that is counted as 20% of our new family planning acceptor at those health posts. So the same in the same next phase from November 2018 to February 2019, we saw the same increased trends from all the health posts. From our 9 health posts, we see the number is actually increased. So total overall, it's 20% of our new family planning acceptors at those health posts. Yeah. So if we go more depth, we see the reference between MBA and family planning with new contraception acceptors. That is actually increases when our initial workshop we started from in last July. It started, and then we had a refresher workshop in October to December. The number is increased. So then this year in January, especially in 2019, many of our midwives, they left the organization, and we struggled with the fund and other things, so that the number of referral decreased a little bit. But if you see the plotted of the with new contraception acceptors, it actually increased. Okay, can you go next slide? So at the same simultaneously at the same time, if you see the mother baby areas, their benefit. So our IOICF improvements through our MBA corner from July 2018 to June 2019, family planning staff referred up to 311 new MBA mothers in each month. So that's a really very encouraging result that we shared with our colleagues in the nutrition team. So the lesson learned, I think the integration of family planning and IOICF service is very possible, even in the early stages of a large scale emergency response. What my experience is, actually the integration of family planning and IOICF, it really worked well, because it actually very cost benefit analysis. If you do cost benefit analysis, we found very cost effective. At the same time, both teams, they really felt very confident. They felt that they are actually not alone. Both teams, they actually targeted same beneficiary, and if they work together, in some cases, it actually benefited both teams, and everybody, they understand these issues. And whenever at the end of this program, in every piloted, when we showed in the monthly meeting, and all of the field teams colleagues, the IOICF council and family planning corners colleagues, the midwives, they actually really felt very happy, and they showed more enthusiastic, and they really worked hard from the next week. So the evaluation found that integration of family planning services with maternal and child health and IOICF services was possible in the early phase of the response, due to an integrated strategy that set of cross-sectoral operational platforms and even proposal development. Yeah. So another lesson learned is collaboration between health and nutrition teams that allowed for shared trainings to sensitize staff on integrated health services. It makes sense to design a health and nutrition program in an integrated way, so that the comprehensive care can be received at a single delivery spot. Because when we started training this health and nutrition team separately, so during the integration process, the health and nutrition teams, we sat together, and then we brainstormed, why not we started this collaboration training between health and nutrition teams. Like whenever the IOICF counselor, maybe they have a nutrition training, and then the health colleagues, we go and then we tag with the trainings, and then we get together all of our IOICF council, and then we train them regarding on this family planning issues. The same issues for the health team. Whenever the midwife trainings we started, we invite our nutrition colleagues to come and then talk with the IOICF things, the counseling, breastfeeding counseling, so that both teams they can utilize the time, because getting the field colleagues frequently in the city level is really difficult. Yeah. Additionally, the programs actually targeting the same demographic of women who actually can benefit through the connected referral systems. That was one of the great lessons learned that we found here. And the reproductive health services like family planning, which might be perceived as more challenging to discuss openly in community, that I already shared earlier. Even in this Rohingya response, a social context is very different than others. Their misbeliefs, social stigmas, their families' issues, their husband and mothers-in-laws, their religious leader, all of these things actually not allowed to discuss the family planning issues very openly. So during these things, when the issues is like that, so that both group can benefit greatly by being integrated into other more accepted health and nutrition services. Yeah, thank you so much.
Wonderful, Noam. Thank you so much for that. That was a very interesting presentation, and it's inspiring, to be honest. It's really, really nice to see something that actually seems so simple, but that hasn't been done actually being done, and that you guys have been courageous enough to actually do something a little bit different that can have a really big impact, as you showed. Okay, using the word impact loosely, but at least it seems very promising. Okay, I'm going to ask now everyone, hang on, I'm just going to change over to different slide deck. Just let's see, 1 second. Okay. Okay, now we get into our section on questions and discussion. I understand that people have not been very active in the chat with asking questions. I do hope, so are there any questions at the moment? Anybody want to speak up? Or you want to share some questions in the chat box? Maybe we could go for some clarification questions first, and then maybe go on to more questions that are about more towards discussion. I myself do have some questions. Since Noam has just finished, I'm going to actually go ahead and say some of mine to get it started. So my first, oh wait, I see some people have raised their hands, so let someone else go first. I'm going to hand over to Alex to manage the questions, and I'll write mine. Over to you, Alex.
Thanks, Sandy. Thanks, everyone. So may I also suggest that the question will be typed. It will be good for documentation as well. But let's start with, oops, Colleen, I can't see you anymore, but I don't know with this MSF. Maybe you can introduce yourself, MSF user. You can go ahead with your question.
Hello? Hello?
Yes, please, go ahead. Go ahead.
Yes, my name is Andrea. I'm from MSF in Indonesia. I would like to ask about the family planning, which was explained in presentation. 22%, or there are some number I don't get, or 20% family planning sector was increasing. So could you tell us which family method in the Rohingya was used, and what was the challenge?
Thanks a lot for your question. Maybe I will ask Noyem as well as Katie to give a brief answer. So 20% increase, what were the methods and what were the challenges before going to the next set of questions? Please mute your mic if you're not speaking anymore. Thanks. Back to you, Noyem and Katie.
Hi, thank you so much for the question. So 20% increases that actually combined with our family planning short methods, and so as we don't have our long-term method actually started in didn't start in that time in our all the health post, because there are some government issues that they actually didn't allow us to in that time. We started with the long term, but now it's increases, now it's changed. But this 20% actually combined with our condoms, our pill, and also the injection. So we found that the injection was in the number of client in injection is high in that level.
Yes, thanks, Noyem. I'm going to follow up just really quickly. We are seeing an increasing number of new contraception users across the board in our health posts. And so we think that this is certainly contributing to it. We certainly saw spikes in family planning referrals as well as new family planning users immediately following these workshops that we were doing. It did fall off over time, as most things do. So we think maybe investing in some sort of supportive supervision or just a little bit more tracking, that might help keep that momentum going. But I think it's important, it's not going to necessarily be a causation. We can't say that these referrals account for the full increase in new contraception users, since the family planning team is also doing their mobilization. But it was such an easy ask, because these women are already at the facility. They're already getting care from one place, and it made a lot of sense for them to access another service at the same place and time. And something that I did want to point out too is that we didn't have, but there were a significant number of referrals from the family planning unit to the IYCF counselors. And so we're hoping to really dig into that data to see if that also contributed to an increase of clients for IYCF.
Okay, thanks. Thanks to both. There is another, is a series of questions. Maybe I start with Colleen first, our colleague Colleen, and she's asking, again, Noyem and Katie, it seems that the effort, meaning the integration, was facilitated by the fact that the services were happening, basically the two services, family planning and IYCF, were offered in the same location. Now Colleen is asking, what could be your advice when this is not the case? When, for example, the health facility providing RH services is not located near the IYCF or the nutrition facilities. What could be your advice based on your experience? Over.
Thank you. I think in that cases, if we don't have same locations, if the different locations of this both health and nutrition, then in that case maybe after the reproductive health or the nutrition services, we can offer our beneficiary that we have that services very near to maybe this health post, and then maybe we support her to accompany someone from our health facility, or then maybe we put it our mobile phone number of our IOCF counselor, or then we can show the way how she can go there. We can do that in same way. That's my understanding. Yeah, Katie, maybe you can add.
Sure. I think it's always possible to integrate the education part and the sensitization part. I think you're always going to have loss to follow-up, increasing the further the service delivery points are away from each other. And that's just because all of us like convenience, and transport is difficult in these situations. One idea, like we've done with integrating with other sectors, is to have one day where a midwife comes to the IYCF center and offers contraception like every Monday of that week, or or vice versa, where a lactation counselor would come to the family planning room and just do some work. I mean, we're always going to advocate to put the services in the same place if possible, just because the clients appreciate that and it makes it easier for them to access multiple services. But it's certainly, the education part can be integrated regardless and should be integrated regardless of locations.
Okay, thanks a lot, and we have interesting questions coming up for both of you. This is from Andy. Is about inputs, resources. What were actually the inputs and the resources needed to set up this system? And as a follow-up question, also, how much time, for example, the staff needed to provide this individual counseling for these complementary topics, either the breastfeeding part in the FP clinics or the FP part in the MBA clinics. And if beside, and another follow-up question is, if beside the one-on-one counseling, were there also group sessions, group counseling, other methods used in both clinics to sensitize the clients? Back to you.
Yeah, thank you, Andy. I think the inputs we actually required, it was not that much, but definitely it required some trainings, definitely stationary and discussion between the agreement between two teams, and some resources for the training and the workshop, really that mandatory. And during the training we had counseling session, we had individual and also the group, like both teams, like IOICF counselor and midwife, they both actually need to understand the family planning, at the same time the IOICF topics as well. So yeah, we had some kind of counseling session, and yes, there are some one counseling, like during the family planning counseling, most of the cases our mothers beneficiary, they don't prefer actually they prefer individual. So definitely, but for IOICF I think it's sometimes it's more needful, I mean, to have a group discussion, or mothers, maybe our mothers can show other mother or encourage other mothers for breastfeeding. So we had that type of counseling techniques we discussed in the trainings, and then we had some demo sessions in the training. Yeah.
Just for the inputs, I can't stress how simple this intervention was, which was why we're having a hard time like writing it up as anything innovative. But these bamboo clinics are incredibly small square footage, and you had a lactation counselor sitting right next to a midwife. And we assumed that integration was happening just because it was in such a small clinic. And what we realized was that these providers weren't aware of each other's skill set or what each other was offering to the same clients. So the intervention was really just putting them in the same room and having them talk about their backgrounds and their skill sets and what they're bringing to this clinic and what they're bringing to these Rohingya women, and just facilitating that conversation. And so it wasn't necessarily a formal training as much as it was an opportunity for professionals to kind of collaborate. And I think that built respect for each other, and it helped with, I think the next question was about the time it took. And I think it helped knowing, oh, I can send this person just next door for more counseling, in-depth counseling on this topic, and I don't need to spend all my time doing that. So I think that's my impression of this, which is, yeah, I want to emphasize that it did not take, we didn't have any money for this. The inputs were just kind of what we already had existing. I think there's lots of ways we can improve with dedicated funding, but that wasn't necessary in this case.
Thanks, and I'm sure your answers are meeting most, if not all, the expectation from those that asked the questions. But there are a few more, and And let me jump to this the question about if this was covered or it was under the umbrella of the interagency cluster planning. What was it encouraged or part of a cluster recommendation, or what can you say about it? Over.
Oh, thanks. This was not actually directly our interagency cluster plannings, but our health sector and even on the nutrition sector, they actually encouraged us. And after our piloting, and we saw that in our last joint response planning 2019, we saw that the inter-sector agencies, they encouraged our partners to have integrated program so that the beneficiary benefited in more easier way, and they can access the facilities easily. So when we shared our piloted result with the WHO, our health sector, they were in Cox's Bazar in Rohingya response program. They really encouraged, and they highlighted that this is a very good practices, and we actually submitted one of our experiences in one of their health sector last best practices in the last year. So it was highlighted in one of the good practices we did last year. Yeah.
Katie?
I actually have Sarah with me, who she was just commenting that IYCF and family planning are a part of the UNHCR.
The IYCF framework. So some ideas on integrating more broadly with the health sector are included in the IYCF framework, just to give folks additional ideas of ways to integrate. Again, they're very simple. The expectation is that they wouldn't cost additional funding, just about, again, professionals collaborating. So that might be a resource. As well, I believe the nutrition cluster, the global nutrition cluster, just completed an integration curriculum for nutrition and emergencies with other sectors, so more broadly nutrition, while the IYCF framework, of course, focuses on infant young child feeding entirely.
Yeah, I do think our cluster systems tend to make this work a little bit more siloed, just because where does this fall? Is it in the health? Is it in the nutrition? Is it in the SRH working group? So as you know, our responses become more integrated, trying to figure out how that will work within the cluster system is really important. So I think that's worth raising to leadership.
And there is another question from Matthew and Dr. Toussaint, sorry for the pronunciation, from MSF in DR Congo. The question is, what has been the role of men, and if they had a role in accompanying women in these clinics, I believe. And also, the follow-up question is, what have been the cultural barriers that the midwife encounter in providing those messages? If you can shed some light on it.
Yeah, thanks, doctor, from DR Congo. The question for men, they really be integrated to accompany women. Yeah, in some cases they are accompanied women, but in the camp situation, most of the time the mothers, they accompanied by their in-laws or by other. But our midwives or our counselors, they are actually requested to accompanied by their husbands. But husbands, they're working in the daytime, so most of the time they are absent. But whenever the husband accompanied, they also try to counsel their husband as well. Yeah. And there are other questions, the cultural barriers that our midwives have encountered in advocacy messages. I think, yeah, the same echo that I mentioned earlier, the cultural barriers across the camps. especially the family planning issues are very sensitive to talk in public. So same is here. And family planning issues, especially using condoms or not having babies, is really carried so much stigmas here. So midwives, they started with the mother's health, started with the health, baby's health. Then they go more depth that we should take some some gap between one birth to another. So then they talk about the family planning, that it also would be very good for your baby's health also. So that this way they actually started advocacy messages with the Rohingya mothers. There are other cultural barriers, like they said, okay, the children, birth of these children, we shouldn't stop them. It come from God, like these things. And the family planning, sometimes the husband, they say they beat their wife when they started with this family planning method. So all of these things, yeah.
One thing I just want to add that was unique about Rohingya population compared to others that I've worked in, there's this huge distrust for any sort of medical healthcare system, just because of the way they were treated by the healthcare system in Myanmar. And so I think this was such an opportunity for integration, because as you see from the skilled delivery rates or the facility birth attendants, women are not coming to the facilities unless they really need care. So if they're able to come and get holistic, comprehensive care while they're there, that I think really helps both their health outcomes as well as building trust, again, with the traditional healthcare system.
Okay, thanks. There are a few more questions. One is from Andy. It's about if you can expand a bit more on the enabling factors. What helps ensure that this integration succeeds the way you have presented it to us? What are the elements, or what are the other elements, so those that were not yet presented? It will be very helpful for all of us. Over.
So like, and the joint strategies, like our, it actually was in our joint response plan, and Rohingya response, the whole, when the IS intersectoral communities, there are the points like integration of the programs, then Save the Children health strategy for Rohingya response. There was also mentioned integration of the program that would benefited by both teams. So in case of these integration programs between MBA and health family planning, that actually enabling a factor, work as an enabling factor. And these factors studies really help us when we shared in high level. Our team leaders, they really like that and encouraged to replicate in other health facilities as well.
Yeah. Katie, you are showing us your Skype.
I think that's Andy. I was Skyping Andy just to say that I'm going to run soon, but I do want to make sure that questions get answered. Yeah, just on enabling factors, I do think huge ones are being in the same location. So I think that's kind of first and foremost. Also, just looking at your population and looking at the woman and seeing what are the many factors and help that she needs for her and her infant at this time, and realizing how your colleagues might be able to also help this person. So I think that was helpful in the workshop to just realize that we're all bringing different care and different backgrounds and experience.
Thanks. There are a few more very specific questions, if we can still have you for a few more minutes. One is about what makes you conclude, and I think, Katie, you were mentioning something, that the increase in new acceptors was actually due to the referrals. I do think you have said something about it. Maybe you can reiterate and expand a bit.
Sure. Again, I think Noyam had mentioned that there isn't a lot of knowledge about contraception necessarily in the Rohingya population, but we have found high rates of uptake once they're learning about it, and the ability to space pregnancies. And so for a lot of these women who were getting lactation support, and hearing from their IYCF counselor that contraception was an option and available at this facility, they were able to make that referral across the clinic. And I think that helped women get access and be more open to accepting family planning. I do think that's one part of a bigger program, but we did see kind of after these referrals started happening, we saw kind of two distinct spikes when the initial training was done in July, as well as when we had a turnover in a bunch of staff, and so did another refresher training in October, I think. So we did see increases at both of those points. So I would like to say that I think this referral system is quite a big factor at play in getting new clients into the contraception room. I hope that that's also true for IYCF because the referrals were going both ways. We just haven't been able to explore that data yet, but we'll certainly share as soon as we do. Did that answer the question?
I'm sure it gives a good answer. I don't know if Noyam wants to add. Oh, I don't see him anymore. Noyam, yeah, you want to add anything?
Yeah, I think it's okay, but just to add with Katie, even there are other influencing factors, but at the same time, when you do a strong monitoring system, that whether you missed your same beneficiary in the same location, definitely it will give you a good chance that the next week or next month you can sit with your field colleagues and stop this missing beneficiary, and started with this utilizing this pocket of opportunity that maybe these mothers will maybe go away without family planning or IVF counseling. But whenever you have this strong internal referral system, and you can do monitor time to time, periodically, regular basis, and that you can share with your field staff, field colleagues. And at the same time, you also shared with your success stories after 1 month with your field colleagues. People feel definitely encouraged, and they started with hard work in the field level. Yeah.
Thanks. There is a question from Nihad. Sorry again for the pronunciation, from Yemen, IMC Yemen. I'm trying to ask it in a different way, and forgive me, but it's about what was the criteria for referral, and do you think that was actually the original question, health workers refer just to hit a target, or what was the criteria for referral to ensure that all the right women were actually referred accordingly? Over.
I think so that we never set any targets. This was just very much a refer people who are interested. I think the idea was to talk to any woman of reproductive age at a facility about contraception, as well as about proper feeding, just because this is a part of education. But in terms of like recommending or counseling, I think, and I can only speak from the family planning side because that's my background, but when you're talking to a woman about accepting contraception, you're often talking to her in her medical history about when did you last give birth, how old is your most recent child, and you ask questions that would get at whether she's having trouble feeding that child. And so I think that's already a part of the medical history in a proper family planning counseling session. And so the midwives were able to identify women who might need some extra support with feeding their infants and children and refer them to the IYCF area. In the IYCF area, I think it's much more just education. And would you like to know more? please go talk to one of our midwives, since the lactation counselors were not necessarily trained on family planning specifically, and that because of that medical history, it does take a kind of clinical, a lot of training to get there. So the IYCF counselors were not doing family planning counseling; they were doing family planning sensitization or education, and it was the same with the midwives in the family planning center. But I hope that I think the referrals were good. Regardless, you can refer someone and they'll get more information. The acceptance of family planning was very much based on what the woman's reproductive health goals were.
Yeah, and sorry to now to switch on the other side, just to aid a bit our colleagues, Katie and Noyan, but if you look from the MBA, the mother-baby areas, I've been in country several times. I think really is an achievement that we were able, thanks to the FP referrals, to expand the reach of the MBA services. And the MBA services were basically based on providing rapid assessments to those women accessing the MBA to identify potential infant-potential feeding problems. And only when these problems, if there were problems, then a full assessment and counseling were actually provided, if not more encouragement and the provision of key messages. So in just increasing the number of these women accessing the services helped contribute a lot in ensuring that, one, the teams could detect problems and intervene immediately and do the appropriate follow-ups, but at the same time to spread and continue promoting the right messages according to the ages of the children of the different women. This is just to add on the MBA component of things. Sorry, I have another question, and it's more on the strategic directions. I think it's a very important question from Judy. And it says, based on this experience, did SAVE decided to include this type of integration in all of its responses, emergency responses? Over.
I think we're certainly hoping to do so. And I think a starting point is integrating our data collection and our reporting systems, because that kind of forces these emergency teams to pay attention to that integration. So a lot of the tools that Noyam put together for his team are going to be like replicated in our current Venezuelan response, also in Mozambique. And so we're hopeful that this will take up and replicate and scale up. We'll be sure to monitor it so we have a lot of learning to share in the future. On that note, I'm really sorry I have to run to another call, but I've so much enjoyed this discussion, and I know that Noyam and Alex can keep answering questions. But thank you guys. It's been really great to talk with nutrition people for once, and I'm really happy this integration is facilitating that. So thank you guys.
Thanks, Katie, from all of us, and I mean really all of us. Noyam?
Yes.
You want anything about directions? Oh, I can help you if you like. Noyam?
Yes. Hi, Alex. Thank you, Katie, being with us. So the discussion that this experience has saved, whether they decide to include integration with other emergency response, I think, yes, we can. I think we should replicate the best practices, one response to another, that actually help our colleagues in the field level, that actually their life become easier, because same beneficiary, if they come in the health facility, if they get both services that they want, that actually really save our time and our energy, everything. So that should be a.
Yeah, and if I'm, again, switching to the other side, I would like to say that looking at SAVE, I'm sure you talk about SAVE, the whole movement. This is really a direction, and it's one of the pillars of our strategies. But just looking at the recent response in Mozambique, where some of our partners here were actively involved. We had another wonderful experience, not on 2 separate clinics collaborating, but on one package of services. And this is including RH and infantile and child feeding, really as one package of mobile services, outreach services. So this remains a pillar of our, it's growing as part of our vision in our responses. And of course, it has to be adapted to the different contexts. But certainly, as I said, it's being repeated, and even its success is being repeated. Now there is another question about staffing and workload. I'm interpreting a bit Andy's question. Seems the staff NOIEM were quite happy, seems to be they were happy about the interventions, and they did not complain, quote unquote, of being overwhelmed by these additional tasks eventually that they were given. Were there, is it really like this? Was it really like this? And were there other negative aspects that maybe you didn't highlight, but it will be also good lessons? So both staffing, was it really all nice and we're all happy about it? And besides staffing, were there other aspects that maybe were not as positive at the start that you had to work out? Over.
So when we started the integration process, it was not that much smooth like present. So some people, they, when some of our group of midwives, they left the response and joined the government job. So it was tough to manage all the referral from MBA corner, because it was huge. Day by day the number is increases. So our one of our fam planning assistant was also then deshouldering all the work. So it was in that time was overwhelmed in some cases. But at the end of the day, after a few months, then when all the midwives, they are on board, so it was then becoming more smoothly. And when the field staff, it's important to show the field staff the changes they are actually doing. They are making a huge change, a beneficiary's life. So from the higher level, I think it's a good opportunity to show them, see the changes you made in your beneficiary life, the increases trends that they are doing counseling, and the number of loss to follow-up is decreasing. Then it actually gives them encouraging thoughts. So doing all of these things, our staff is now, they are all are encouraged now.
Thanks, Noyem. And I keep going, Andy, if you want, you can stop us, but there is another question from Main Mohammed Chowdhury, and is asking how sensitive was to establish such a referral system across these components, and what was, how wide was the acceptance by the refugees, by the Rohingya? Over.
I think to establish the referral systems like these with the different components, like we did with IOICF and fam planning, it was I think a good system. And the way we do keep confidentiality their information, like from fam planning to IOICF counselor. In some cases, this referral system actually worked very well, because sometimes when you shouted, okay, this IOICF mother needs fam planning counsel, show her the fam planning room. Instead of doing that, sometimes when our staffs, they accompanied them very silently, just to receive them by midwife or fam planning counselor or the IOICF counselor. That become more actually acceptable way, even with the refugees as well, because they don't like to share these things very openly. And when our family planning counselor or our IOICF counselor refer or send a patient or a mother to IOICF counselor or a family planning counselor, so that they already mentally know that this mother really wanted to know about family planning counseling or IOICF counseling. So that actually helped them to initiate the counseling session. So that means the initial discussion, initial counseling or discussion regarding this family planning or IOICF already done by other colleagues. So it's helpful. So the diffuse also like that colleague, the beneficiary, their mother, they also like that. We found that, yeah.
Thanks, Noyem. Now there has been few questions that I didn't ask immediately about, and I call also Nandi, and of course Noyem and your team, about if it's possible to share, I think, the presentation, to share the forms, any module that has been used. I think these are few questions that were asked along. So maybe again, Noyem, I don't know if you can answer now. Andy, maybe I can give it back to you, Andy, also for the closing and other requests and information. Over.
Great. Go ahead, Noyem.
Yes, definitely. Yeah, I can share with MD and other colleagues who want. Yeah, I would be happy.
Okay, great, fantastic. In fact, that's a good point, is that after the webinar, we will share the slides. It's been recorded. The webinar will be on the TechRRT website, and I will share the link with you. So before we wrap up, I really just wanted to first say thank you to Noyem and to Katie, although she's gone, and to Alessandro, as you guys have been very instrumental and active in the program, and it's been super interesting to learn about. For me, it's been interesting to hear how something, as Katie said, so simple can, and something that just being well connected and complementary, that somehow it in fact feels natural, it can have such a good effect on people. From what I heard, it sounds like a very cost-effective way to be able to increase service uptake of both infant and child feeding services as well as family planning services. So it seems like something that we don't have to complain, we don't have the resources to do it, but we can actually just go ahead and try it. I was really pleased to hear about that staff didn't feel overburdened, and that it actually helped them feel relieved to be able to make a referral, to not have to go into too much detail. And so, because that's an obstacle that we are often having with integrated programming, is overburdening staff with too many different things at the same time. In particular, when we're talking about community health workers, obviously this is slightly different, and it's a positive factor. It demonstrates to me, as Katie also mentioned, that it was holistic programming with comprehensive care, something that as long as I've been in humanitarian work, I am always surprised at how much we are in silos in our different technical areas. And in fact, all we need to do is think about that child and the mother that are at the center, and see how we can make better programming for them. So it was nice to hear, Noyem, when you mentioned about that it was important to demonstrate to the staff the change that what they were doing was having for the people themselves. And I think that's something that we can all use in our programming in all sectors, integrated or not, to keep those people at the center of what we do. Okay. I know that there's been one more question that's come in since I've been talking, and so I'm going to put it out there. We will be finishing within the next 6 minutes, so don't worry, everyone. The question is from Akram from Seoul in Yemen. Can you make a quick explanation for the M&E most important differences between health and nutrition interventions? I'm not 100% clear on the question, Akram, but I believe you'd like to understand how the M&E for each of the different components worked, I believe. Noam, could you shed some light on that, please?
Yeah, I think we mentioned during the presentation that we established a robust monitoring system, and finally the evaluation that we found that there are chances to work together, both teams, like RH and nutrition team. So the health and nutrition team, in these cases, I mean, and this integration, we, due to the strong monitoring system, we really had a good result, because in some cases when we found that our beneficiary lost to follow up, then we immediately we did able to understand the gaps, and then from which level in the field, then we could recover that, because the monitoring and evaluation, we had started with some tools, the daily output tracker from the nutrition and the impact system from health. Then we cross-check with this M&E monitoring and evaluation systems, and then it really helped us a lot.
Great, thank you for that explanation. Okay, now I'd just like to highlight, I think all of you have seen that in fact this webinar is the first one in the series, and so I wanted to make sure that you know about the next ones that are coming up in case you haven't registered, and if you want to, just drop us an email to the TechRRT2 email address that's at the bottom there. Next week, next Wednesday, same time, we'll have the webinar on baby-friendly spaces linked with mental health and psychosocial support in Central Africa Republic. The organization presenting is going to be Action contre la faim. On the 31st of July, we'll have one that's being presented by WFP on general food distribution with integrated IYCFE in the Democratic Republic of Congo. And finally, at least to get us through the summer, we will have a final one on the 7th of August, which is looking at the IPC, so the Integrated Food Security Phase Classification, and the use of IYCF data. And that will be presented by IPC. So please do drop me a line if you haven't. Finally, before we wrap up and I fully say thank you, I have a couple of questions. One, we have a user we've got an evaluation of our webinar, and we would be very appreciative if you can just jump over to the chat box where Ben will be posting the link to the survey that we have. It won't take you any time at all, just a few minutes, and we would very much appreciate your input, and it helps us to make these webinar series even better. So that would be much appreciated. And finally, one last thing is that I know that we asked at the beginning that everybody introduce themselves and tell what your name is, what your role is, what country you're from. We didn't have everybody do that, so if you haven't, can you please? And if you had more than one person at your computer, if you can tell us everyone who was participating, that would be much appreciated for our own monitoring purposes. So otherwise, I would want to wrap up there and say a big thanks to Noam and to Katie for the presentation and the project in general. I think it's a fantastic demonstration of what you can do with very little to make a big difference for people. And I am looking forward to seeing more initiatives of this kind. I also want to thank Alessandro for his help with the with the webinar today, as well as Ben. And I really want to appreciate everybody who's participated today. Thanks so much for your time in coming, and I hope that you found it valuable. With that, I think we finish right on time. And this survey, if we don't have enough people responding straight away, I will hold on to all the materials that I promised to send until I see a good enough response to that. Sorry, it's a little bit of a mean way to do it, but we do need to have those responses. So please jump over there quickly, and then I will happily send everything out straight away. With that, enjoy your afternoon, evening, day, depending where you are.
Thank you so much, Andy.
Thank you, Noam.
Thank you all who listening us.